Thank you for this opportunity to present this webinar. This is on basically from Clinical Engineering Australia, and it's all about health leader opportunities. My name is Melvin Mazid. I'm the chair for the National Committee on Clinical Engineering. Next slide, please. The overview of the Australian healthcare system. Generally, we're a universal public healthcare, and it's called Medicare. It's basically predominantly taxpayer funded. There is a private system that runs in parallel, which is user pay. Basically, the responsibilities is the funding occurs through the Australian government, and also we've got states and territories which basically run and manage the public system. Hospitals, as per the 2017-2018 data, is basically the public is around 693 hospitals, and the private is 657. And there is a distribution of beds accordingly on that. The healthcare funding approximately, which is substantially large, is 30% of expenditure, of a total budget expenditure. Next slide. The overview of the on generals of the CE or health technology management in public hospitals basically are based in public hospitals, I should say. There are some in private hospitals, but predominantly we exist in the public system. CE reporting is predominantly within those hospitals or the health networks. And there is no representation or interactions with the government levels in Australia. Next slide. Okay, so some of the challenges that we pick up in for CEs in predominantly in Australia is around visibility, where we can be basically down to about 4 levels in the organizational chart. So when the first tier is of course the CE, so any 4 levels down from the CE is the normal levels that a CE can appear in. Where that poses is communication, of course, the challenges around and getting greater visibility. The other side of it is organizational fit, the changing leadership, change management, priorities, and also reporting lines and funding. I will, and we'll discuss a bit more later on as we go in this presentation. Next slide.
So I'll take over if you like, Melvin. So I'm Adrian Richards. I'm the co-presenter here, and welcome to everybody. As Melvin mentioned, he's the chair of the National Clinical Engineering Committee. I'm on the Engineers Australia Biomedical Engineering College Board. Engineers Australia is the peak professional body for all engineers in Australia. The body of knowledge for clinical and biomedical engineering sits with the college, and I'm a member of the governing board for that college. So getting on the topic of our talk here this evening or this afternoon is just talking about reporting lines and how we communicate with the, I guess, the power brokers within our organisations within which we work and operate. It's very dependent on the hospital or health service in which the CE service is being provided. There's no real consistency across departments or services within the country. And there's many examples. There's really a continuum upon which people exist in terms of the reporting line. I've listed some examples there. It varies from the Chief Operating Officer through corporate or clinical services lines, support services, the CTO is sort of a bit of an emerging, maybe a bit of a trend. Medical nursing, reporting lines, or even finance is one that we're seeing a bit of as well. You might see some common theme there, and really you can split those into, I guess, 2 larger groups of either clinical or a non-clinical reporting line. And this is, I guess, here in this country at least, a fairly old topic of debate around which one of those is potentially most productive or most advantageous, and it depends on the circumstance. We'll just talk a little bit about that. Some examples there: that reporting along a clinical services line can include, for example, maybe links in with allied health support services. Typically, we might see that as having some common reporting line with, say, pathology services or medical imaging. So that really depends on the organisation and just the circumstances that prevail. Next. Okay, next slide. So looking at those two larger categories, clinical and non-clinical, we'll just have a look at some of the pros and cons we see of each of those. And I think that both Melvin and I have had some degree of experience probably reporting to almost every one of those. Certainly from my own perspective, reporting to a chief operating officer who at the time was a nursing professional was probably a highlight, because you don't need to explain to them some of the clinical challenges and some of the clinical risks you're trying to address. They understand that, and they're more interested in how you would be actually addressing them, compared to, say, a financial report where they might have a vague idea of the function you perform, but have a very clear idea of how much money you spend when you're doing it. So you might constantly be sort of educating those people on your actual role and function within the organisation. But here's just some thoughts around the advantages and disadvantages of each of those two larger groups, clinical and non-clinical. And a clinical reporting line, you really become part of the patient care team. I guess the clinicians see you as their peer, and you play a very active role in the provision of patient care. It does remove what some people might see as hard links or confusion between clinical engineers and facilities engineering, and that helps as well. There's still at times confusion as to where those boundaries are, and that helps to delineate. The downsides can be in the clinical reporting line. There's a lot of pressures and a lot of things going on in medical nursing land, and that can be distracting, and you might be somewhat of a bit player in that setting. You need to, and this depends on how almost individuals and departments position themselves, you need to establish yourself as a peer amongst the medical professionals, and it's important that they deal with you as an equal and not believe that you're just subservient to them. And links with IT and IT services becoming increasingly important, and that might not be as obvious if you're going down a clinical reporting line sort of pathway. Next. Going down a corporate reporting line, the clinical connections are broken, but you can still potentially have quite a high impact, because you're working amongst people, with people who, and reporting of such a clear understanding of some of the clinical impacts. So you can capture their attention, but you might have to be educating them about the reality of some of those impacts. And it can provide links, although can be a plus and a minus, but links with other providers such as IT and informatics. That's obviously a growing trend within the CE field, and those links can be very valuable and built upon. The downsides of a technology or corporate reporting line is just getting bundled into engineering and support services, and considered maybe not so much a part of the clinical or healthcare provision team, and a support services just providing just general engineering support to the broader organization, and that can certainly be a downside. Next.
So just before we go to the next slide, I just want to pick up something Adrian's brought up there. Is in regard to my experiences where reporting to a corporate leadership chain. Some of the challenges is education and providing the knowledge of what clinical engineering is about. It's the biggest challenge that you face when reporting in that line. Some advantages, and Adrian's picked up on that, is basically, you can, so in a case where I've been involved in, where there's the chain up is to basically the director of finance, and then you do have some of those budgetary constraints that you may face in other reporting lines available to you. But the biggest problem I faced was trying to educate, reinforce, and the value that a clinical engineering department serves for the organization. I'll sort of let Adrian sort of talk on to maximizing impact.
So this really is, and building on what Melvin said, a clinical versus corporate reporting line really depends on how the clinical engineering department, the service, and the individual within it choose to position themselves in the organisation. You might not necessarily have control over that, but you can have an objective to align yourself with one or the other of those and do all the things you need to bring that to fruition. We'll move quickly through maximising the impact because there are many things that you need or can do to really, I guess, whatever reporting line you're engaged in, as to how you actually add value to the organisation, how you minimise the clinical risk and maximise the benefit that technology is providing in the provision of healthcare. One that has worked particularly well for me is becoming engaged in capital equipment planning and prioritisation. And when I started in the organisation that I'm working currently, that really was a lot of medical staff sitting around the table having a debate and negotiating what they think was most important. We've changed that substantially now, and probably within the organisation have a series within every level of the organisation of about 7 or 8 equipment committees, from departmental operating groups through to overarching organisational groups, including engagement in new health technologies committees and new health technology assessment. So that really is embedded biomedical engineering or clinical engineering into many, many formal processes and forums within the organisation, and that gains credibility, engagement, and you have a seat at the table where many important technology-based decisions are made, are in their procurement, their application, and ultimately sort of their lifespan. So we can just skim through those, and they're examples of where a CE department can become involved and add value, and it depends very much on the circumstance within an organisation, but these all present themselves as opportunities for engagement at whatever level is possible. Next.
I suppose something we'll sort of expand on some before we talk about going into sustaining the agenda. Is the qualities, I suppose, in leadership. What I found, my experiences in dealing with the corporate side of leadership is basically providing evidence-based data, and framing that in a very simplistic, communicable way of what your agenda is as a department. That's the biggest challenge, and also getting that information readily available. The other side of it is early on is building a trusting relationship. So those experiences that I found was productive or advantage was basically in relation to holding regular meetings and trying to always having those agendas met, basically. And I suppose Adrian can pick up on those some of those agendas.
Yeah, certainly providing simplified data and dashboards, and particularly selecting the data that is presented and hitting the target. And if you get to present at the CEO board level, make sure that you don't provide too much data or overcomplicate it. At that level, you might get 30 seconds at a board meeting where your data is analysed or interrogated. So you really need to provide data which is very punchy and very specifically targeted at the audience. And I would suggest there I'd be looking at the impact that the department is having on the risk profile of the organisation, for example. And so there's little point in this overwhelming with large amounts of data and KPIs, which ultimately is going to be wasted on them. They simply won't have time to absorb it. We're probably getting close to our time, I think. So you might just want to sort of wrap up there, Melvin, and just summarize some of those key points.
Yeah. So just the previous slide, just quickly, basically some of these things can assist and help a CE department. Some of these have been good. Is having one of the important ones is the business plan linked to the yearly organizational goals. I think that's fairly important. And also if you can use some other tools like quality programs, which is like ISO 9000, N1 or national accreditation programs, and there's a link there that you can find useful, which we have very good in Australia. And audits. Audits can highlight the deficiencies, but it's an opportunity that can be gained. That's all in regard to trying to, for a CE department to always keeping the agenda and focus on the department within a large organization.
Encourage people to look at that website, the Safety and Quality, their government safety and quality guidelines, and hospitals here in Australia, excuse me, public or private, will live or die by meeting those standards and being audited against them very regularly. And there's good information to be learnt there, that's for sure. And they're a good reference source.
Thanks so much, Australia. We're going to move on.